asked Dayton to keep a timer with an audible alarm. We're going to go 2 minutes if we can. I know everybody is here and anxious to get their testimony through. I'm not even sure if everybody who is scheduled to speak has fit into the room. So I think Francie's going to try to manage if anyone's out in the hall and if we have any audio in the adjoining room. So welcome. This is Social Services Budget Committee, and we have a ton of conferees and presentations today, and we're looking forward to it. So with that, and not to waste any of the precious time that we have, the first person I have is Dr. Christina Kovacs from Behavioral Health Systems. Welcome to the committee, Christina.
Good afternoon, Chairman, members of the committee. Thank you for allowing me to speak. My name is Dr. Christy Kovacs. I am the Chief Clinical Officer and co-founder of Behavioral Health Solutions. We're a behavioral health group that's headquartered in Henderson, Nevada, where we manage behavioral add-on programs like the BCCP, the Behaviorally Complex Care Program. We've managed that for 10 years. It is a program with a behavioral add-on to nursing homes between $111 and $326 a day for patients that have a history of difficult and documented behaviors and therefore have difficult time finding placement from transition from hospital acute centers into lower cost settings, which are nursing homes. And BHS specializes in providing staff training, support, and wraparound services to nursing homes to give them the resources and support they need to be able to admit these types of patients and provide appropriate care. As we expanded into 14 additional states, we found that many states had programs similar to this because they had similar pain points. And now we manage programs in Idaho, Utah, Arizona, and Montana. And these programs are becoming more essential over the last 15 years as we've seen an increase in psychiatric and neurocognitive disorders with associated behaviors. In order to admit and properly care for these increasingly behaviorally complex residents, nursing homes require specialized staff training and clinical support, and these resources require additional funding. And Kansas has the same difficulties as we have in the other states with placement for these patients. They're staying in hospitals well past the time that's appropriate, taking up those acute beds that really should be used by somebody in more need. We've seen patients stuck in those hospitals for over 100 days when it's not appropriate any longer. And so nursing homes are reluctant to admit these patients. It creates staffing and regulatory challenges, and the inability of nursing homes to kind of manage these patients are causing these extended hospital length of stay, which increases cost and results in poor outcomes. Oh, already, okay, really quick, we're proposing a value-based program capped at 125 patients. It's $175 a day daily add-on rate.
Okay. Thank you so much, and I do apologize for the time. You did great.
Thank you.
Very welcome. All right, I know he's here because I saw his face. Matt Fletcher, Executive Director, Interhab. Oh, there he is.
Thank you, Mr. Chair and members of the committee. I'll be very brief in my oral remarks. I refer you to my written testimony, which includes great detail regarding the concerns that providers and families in the IDD system have expressed to you all regarding proposed KDADS systems change initiatives. There are multiple initiatives that KDADS has proposed to make to the IDD system within the next 2 years' time. These are all large-scale initiatives and largely have been developed without significant input from providers and families, and those proposals suffer as a result. What I'm here to say to you today is that on behalf of the provider community, there is a widespread acknowledgement that the state must respond to federal concerns. No one thinks we can get away with not complying with federal rules and regs. What we're here to ask you to help us with is to make the KDADS proposals better. These proposals have been developed without significant provider and family input, and they suffer as a result. We know we can make these proposals better. We asked for the opportunity to make them better, and that's going to involve, unfortunately, legislative intervention because KDADS does not show any signs of opening up these proposals for reevaluation. So we ask for your help We think the legislature, through some language in the KDAD's budget, could bring KDAD's back to the table. InterHab, I will tell you, has engaged 2 different consultants with national credentials to assist in this process. We've also formed 3 internal work groups of subject matter experts for the purpose of developing concrete recommendations to make these proposals better. We ask that you give us the chance to do so. Thank you, Mr. Chair. I'll stand for questions.
All right. Thank you, Matt. If we have a little, how are we on time, Dayton? Oh, we had 5 seconds. I will say, we had this situation last week or a few days ago, and I'm not, if you can hang around, we're going to get through everybody, and we can have some one-on-one questions at that time, and I would mention that to Christy if she's still here, but I do appreciate it. And the other room is open, okay, for spillover. Okay.
Thank you.
So with that, thank you, Matt. We're going to move on to Megan Shreve, Associate Director of InterHab. Megan?
Chair Bueller, members of the committee, thank you so much for allowing me to speak on behalf of InterHab's members. My name is Megan Shreve. I'm the Associate Director at InterHab. And today I stand here to ask you for increased funding for the IDD system. Kansans with IDD are arguably the most vulnerable population in our state, and IDD providers are doing what's best and most cost efficient for everyone receiving services. That job continues to get harder in a system that's chronically underfunded. By serving Kansans in their home communities, we are saving the state money by avoiding costly institutionalized care, not to mention just doing what's best for our loved ones. While I'm newer to this position at InterHab, I've worked alongside of our members for 7 years, and I've seen the measures and providers go, and their providers and employees go to make sure they're providing the best possible services in the community. I will remind you that the IDD system does not have a system in place for inflationary increases, so the need to ask for continued funding is necessary and why I'm standing here today. Ultimately, providers want just one thing: to keep pace with the rising costs of doing business. And they can't do that without your help. They rely on you, the sole funder of home and community-based services, and sporadic state funding forces providers into a loop of unpredictability and constantly making sure that they have to adapt and making it impossible for them to plan for the future. For that reason, and you can see the details in my written testimony, providers are asking for a 6.5% rate increase for the IDD waiver and adjustments for CDDOs, targeted case management, personal care services, and additional funding for 14C transition. Please help us build a system capable of meeting the needs for Kansas who need you most. That is all. Thank you.
Well, hello. Thank you, Chair and members of the committee. So I am going to try to only talk about the things that Megan and Matt haven't mentioned. The provider rates are really critical, so I please ask that you read my points on the testimony there. So I'm going to focus on the KDAD's changes and some of the concerns there. Many providers like myself could speak for hours on the impacts of all of these changes, but I'm going to give you just one example of one part of one of the changes. So the elimination of center-based day services for most individuals in our services will require them to be out in the community for 25 hours a week. That's an ideal we can all get behind, but there are significant feasibility challenges. Most of our community businesses have significant accessibility issues. While ADA has improved things and most of the time we can get through the front door, there's a lot of accessibility challenges right beyond them. There are financial limitations, restrictions from bringing in and consuming food, inaccessible bathrooms, and time limits. As one example, we recently went to our local bowling alley with a group of our individuals. It took a group of 7 individuals 25 minutes to unload for a 1-hour event. The space to bowl was extremely crowded and they couldn't even get through one game. When the time came to eat, most of the individuals present required adjusted food so that they could swallow. We brought scissors and a portable blender to prep the food. We had a line of staff cutting up and blending pizza. Our portable blender took 10 minutes to blend one person's food and then it died and we had to dispatch staff to get another one. During this time, an individual in a specialized wheelchair needed their brief change. We have a special wagon that we bring with all the stuff we need. It includes a portable changing table that did not fit in the bathroom. After reviewing all of the options available, the best place to change this individual was on the bathroom floor. After less than an hour, we had to start loading up to leave, so the next group of bowlers had space, and most of the individuals that need adjusted food didn't even have a chance to eat yet. That single event was exhausting, a lot of fun, but exhausting for everyone involved, and it didn't even account for a quarter of the hours that we would have needed to be out in the community that day. There's a lot I could see, but I just want to note that that's one piece of one small part of one of these changes. I appreciate your time.
Pretty close, pretty close. Been called worse. Chairman Bueller, all the members of the committee, thank you for welcoming me to have a few moments. I'll be brief. You have my written testimony, which included an attached values document, which I will not go over, but hopefully give some helpful background. My name is Jerry Michaud. I'm the president of Developmental Services in Northwest Kansas. We are an organization 57 years in the making, spawned from the grassroots of parents wanting options for their children. And out of our timeline, there's a little history in here. We were CMRCs once upon a time. In the mid-90s, we, through the Developmental Disability Reform Act, were formed and took on the role of CDDO, Community Developmental Disability Organization. So we wear multiple hats. We've been providing services to people for all those years. We've been providing administrative oversight for those years. We provide targeted case management for many people in rural Northwest Kansas. We cover the 18 counties of Northwest Kansas. So that's a little bit of who we are. The concerns that we face, you've heard some in previous testimony, concerns about the amount of change that's rolling down. From my perspective, I'm 33 years with this organization, committed to this. Our mission is to serve people. Our interests are to serve people and their families. That's what it's about. That's what we've always been about. We have key roles within our CDDO. So this conversation about a conflict of interest, I certainly understand it, but it's something that's relevant to every person in this room in one way or another. It just plays out in a structural model. But there are safeguards, and that's an important thing. In the 90s, when they passed the DD Reform Act, the legislature then knew that there were overlapping roles. And they built in safeguards within the DD Reform Act, which we followed today. We have quality assurance, we have oversight, and I'm going to wrap up very quickly. I got the sign. Anyway, it's very important that we have a method to look at all the options for the system and system solutions. That's really the crux of the issue. We've had rapid fire things. I don't want to go into all the details. Rachel touched on one of those situations. It has to make sense. Has to make sense, our path forward. So there's message in there about the need for rate adjustments for our system. We had a bump a couple of years ago, which was enormously helpful, but inflation, as we all have experienced, has bit into that, and I'll stop there.
Gary, thank you so much.
Thank you. Thank you for the time.
You bet. Okay, next up we have Laura Ritterbusch, Goodwill Industries of Kansas. Laura, welcome.
Thank you, Mr. Chair and members of the committee. My name is Laura Ritterbusch. I'm President and CEO of Goodwill Industries of Kansas. Our territory is roughly 2/3 the state of Kansas, from Emporia all the way to the western border, and we employ roughly 750 people. For over 65 years, we have been and will continue to be tireless supporters of those in the IDD community. We really appreciate the legislator's recent work to move 500 people off the wait list to receive services. However, providers are unable to handle major infrastructure changes while serving additional people. We are concerned about the rapid sweeping KDAD's changes in their day services modernization, specifically the unbundling, which is moving people into the community, which was referenced earlier. And while there are good intentions there, we want to acknowledge that it is unfair to the individuals we support. Planned KDAD's changes force individuals out of their current services instead of considering individual needs and wants for their daily lives. We are eager to collaborate on enhancements with KDADs to support individuals in their choices to experience dignity and pride through the power of work. Currently, Goodwill provides case management and day services to the IDD community. But due to all these sweeping changes coming, we have made the hard decision to only provide day services. And that was a tough decision for our organization to make. We love individuals that we work with, but it is so hard to respond to all these regulatory changes without having negative impact on the people we are serving. And we know we have to fully focus on those that we serve in our day services. Again, we are committed to working with KDADs and making appropriate changes over time. It is too fast and too quick. We need them to slow down and hold on in implementing any changes until we've had a chance to collaborate and have a meaningful seat at the table. Thank you for your time, and I'll stand for questions later as needed. Thank you.
Thank you so much. My mic was off, pardon me. Okay, next, I have Ron Fugate, presenting as a parent. I've seen Ron before. Ron, welcome to committee.
Thank you. Thank you for the opportunity to speak with all of you today. As a parent and IDD advocate for the past 50 years, I'm appalled at what I hear. I've referred to the significant shakeups to the IDD service delivery system proposed by KDADs. Now, consider these sweeping changes to day services work programs. Eliminate the work activity programs, and if this happens, I know of one service provider who will lose 20 clients because they are employed at Garment Industries as a work group, and another 8 at other employers. If we limit the employment in center-based jobs to 6 months, I know of 98 clients served by a single provider who will lose their center-based jobs after 6 months, okay? Even if these displaced employees can find other jobs in the community, there are not enough supported employment resources across the state to help. And don't forget vocational rehabilitation services that help jobless clients find employment. My son has used Voc Rehab 3 times in the last 10 years. And I know VR struggles to serve the IDD population. And without significantly increasing VR support, any large-scale community integrated employment will falter. Has KDADs run the numbers on these matters? Do they know the financial impact on the state and on taxpayers? How many trained professionals are needed to implement these changes successfully? And what will the cost be to service providers and families? We parents want our sons and daughters to be free to make their own choices. And this includes their choice to work at center-based locations or in group activities where they're mostly content and happy. So KDAD says now you can't work at those jobs, or you can only work at center-based jobs for 6 months and then you're done. Do these actions disregard the spirit of the Medicaid final settings rule about respecting the choices of people receiving services? It's time for KDADs to reopen discussions and planning for service providers and families regarding these proposed system changes. And do it for the sake of our loved ones and the providers that we've entrusted care of our sons and daughters, because in the end, they are the ones who will bear the consequences of poorly conceived solutions that contradict the intent of the Medicaid final settings rule. And I stand for questions if you.
Ron, thank you for your time. I very much appreciate it.
You bet.
Okay, next we have Hal Oberholzer, Senior Business Development Manager, Maxim Healthcare Services. Hal, welcome to committee.
Good afternoon, Chair Beeler and Vice Chair Carpenter. My name is Hal Oberholzer, and I'm the Senior Business Development Manager of Maxim Healthcare Services over the entire state of Kansas. Maxim is a provider of specialized medical care in Kansas through the home and community-based waivers. This service provides RN and LPN extended hourly nursing in the home to Kansas's most medically complex population. These patients typically require care around the clock, anywhere from 8 hours a day to 24 hours per day. Typically, these patients have cerebral palsy, brain injuries, and chromosomal anomalies. The patients require feeding tubes, tracheostomies, and ventilators. Let me paint you a picture to visualize these services. When a patient is discharged home, the patient's living room or bedroom is transformed into a mini NICU or a PICU or ICU room. Alarms and breathing machines are constantly humming. Closets are filled with medical supplies and backup ventilators. Nurses are required to provide hourly care. Maxim's ask for the committee is to increase the specialized medical care rate to $55 per hour. We are exceptionally happy the committee and their colleagues have given increases to the program over the years, and thank you. However, the increases have been partially funded, and we want to continue to expand this program. With the focus of CanCare 3.0 on outcomes, we need a competitive market rate to compete with other healthcare settings in other states. This rate will allow providers to better recruit, train, and retain their nurses to provide this care. At almost $12,000 per day in a NICU or PICU, anything that can reduce delayed or unnecessary hospitalizations should be evaluated. We need a reimbursement rate that allows the provider network to function efficiently, effectively, and most importantly, increasing patient care. These reasons are why we are asking to move the reimbursement rate to $55 per hour. Thank you for your time, and I'll stand for questions.
Hal, thank you very much. I'm going to roll right down to Tara Mays, Vice President, State Legislative Relations, Kansas Hospital Association. There she is. He didn't even get it all the way out.
Good afternoon, Mr. Chairman, members of the committee. I am Tara Mays with the Kansas Hospital Association. It's great to be here with you again this afternoon. Just wanted to highlight in my brevity in terms of approach, a couple of things that we want to hit on. Of course, our hospitals are continuing to have patient transfer issues, which I mentioned during my testimony on the KDHE budget. So any investments that you all can make really in allowing those folks to be able to be transferred to the right care at the right time would be very beneficial to our hospitals, including add-on payments and Medicaid rate increases for long-term care settings that can really help those patients get to the right care setting at the right time. In addition to that, investments in behavioral health are critically important. And along those same lines, one of the programs that you all started in 2024 was the Behavioral Health and Observation Patient Observation Program in the state of Kansas. It reimburses our hospitals for the times that those patients are sitting inside our hospitals. We're statutorily required to watch them 24/7, and we were not being paid at all. We now have a reimbursement program. We appreciate that both the governor's budget and the House budget does include funding for that. It does both recognize the right sizing of the program. However, we do believe that that program needs to be funded at least $3 million for fiscal year 25 and 26 as we go forward. So with that, Mr. Chairman, I'm happy to stand for questions at the appropriate time.
Tara, thank you very much. Appreciate it. I'm going to move next to, and I've seen him, Sean Gatewood, CO, Administrator, CanCare Advocates Network. Sean? Came from the spillover crowd. Sean, welcome.
The holding cell.
Well.
Thank you, Mr. Chairman, members of the committee, for allowing me to come and testify today. I'll be very brief. In our testimony, we have some support for a few of the governor's budget items to enhance funding for some of the HCBS waivers. There's some issues with, network capacity in those areas. But I want to kind of focus on the IDD and PD wait lists and an elimination of those. Many folks, I'm sure the entire committee supports getting rid of those wait lists. I think it would be important to kind of work on how we manage, particularly on the PD side. It seems to be fairly uncertain who is still in the state needing supports, to sort of actively manage that list so we know exactly where we're at would be very important. I think that also needs to be done to some degree on the DD side. They just have a little more contact having the CDDOs. We're also carefully monitoring the community support waiver. We would like to see waiver slots added to the IDD wait list, or to the IDD program as it stands. So with that, I will stand for questions at the appropriate time and just refer you to my written testimony. Thank you.
John, thank you so much. I appreciate it. Okay, next, Monica Kurtz, Administrative Officer, Health Source Integrated Solutions. There she is. Welcome.
Thank you. Thank you, Chairman Bueller, members of the committee. My name is Monica Kurz. I'm the Chief Administrative Officer with Health Source Integrated Solutions. We are a not-for-profit headquartered here in Topeka, Kansas, providing a variety of integrated behavioral health solutions across the system. We are a 988 provider, as well as providing telehealth screens for state hospital and state institute alternative stays, and local crisis line services. I'm here today to talk about 988. As I am sure the members of the committee know, we went live with the 3-digit mental health and behavioral health crisis line in July of 2022, and I'm happy to report that we are seeing phenomenal utilization of that line in the state. In fact, since last year, August 2023 to August 2024, we've seen a 68% increase in phone calls from Kansans and 110% increase in text messages and online chats from Kansans to Kansas centers. As such, we're really asking the committee to take a look at an enhancement to the 988 fund. We are asking for a $3 million enhancement to the KDAD's budget, really to address 3 primary things. One, as I said, we have a pretty good increase in that call volume and the text and chat volume. We want to ensure that we're able to stay at a 90% answer rate in Kansas, meaning that those Kansans are getting their phone calls answered by folks who are familiar with their local resources and able to connect them to their local CCBHCs. We're also looking at more support for our quality assurance programs and a technology solution that would ease referrals to our alternative 911 responses like mobile crisis teams, again, centered at our CCBHCs. I appreciate the committee's time, and I'm happy to stand for questions at the appropriate time.
Monica, thank you so much. Okay, next we have Andy Holtberg, CEO, Breakthrough Episcopal Social Services. Andy, welcome.
Thank you. Good afternoon, Chairman Bueller and committee. On behalf of the Kansas Clubhouse Coalition, I'm here to advocate for the expansion of life-saving approach to mental health recovery for people experiencing SMI, severe persistent mental illness. As you may know, 1 in 20 U.S. adults experience severe mental illness each year, and in Kansas, that equates to 111,000 lives. Our program is an intentional, supportive working community. Members and staff work side by side, developing meaningful work, meaningful relationships, and a safe place to belong. This is an approach to mental health that's rooted in the fact that community itself is a powerful therapy. We've seen incredible outcomes through our program so far. We have 6 different locations. When we received the KDAD's grant 6 years ago, we only had 1 location, so we've expanded greatly since then. And out of those 6 locations, we have a 42% employment rate and a 90% reduction in long-term hospitalization, which you can only imagine what this cost savings is on that. It is an affordable and an impactful program that has been developed over 70 years. There are 360 clubhouses worldwide. One research paper, which I included in our written testimony, is from Fountain House. It was done in 2024, and it shows that expanding Clubhouse to serve just 5% of adults with SMI could generate over $8.5 billion in societal benefits through reduction of hospitalization, homelessness, incarceration, and employment. So what we're asking is for the lottery vending machine cap to be lifted from $8 million to $16 million. 75% of that goes to the mental health centers through crisis intervention, and 25% goes to clubhouse expansion. If we are funded with this extra funding, we can expand to other communities. Right now, we are in Wichita, Topeka, Olathe, Newton, Salina, and Hutchinson, and we would like to expand into Lawrence, Great Bend, and Hayes if we are awarded this. Thank you for your time.
Thank you, Andy. Next, I have Kyle Kessler, Executive Director, Association of Community Health Centers of Kansas.
Good afternoon, Mr. Chairman, members of the committee. I am Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. It's great to be in front of you all again. Last week, we testified in support of the state mental health hospital budgets, and our association, as a reminder, represents all 26 licensed CMHCs around the state. serving nearly 150,000 Kansans annually with over 4,500 employees. And I'll keep my comments brief as well, because I really am the junior varsity in terms of our association, and we have several after us, or after me, who will be speaking more specific to their communities and in several faces you all know. But really, we have a couple asks in front of you from our association. One is that in order to meet the demand for services and account for the growth in the number of persons who are served who have no insurance, our association, again, is the system or network that provides service to treatment regardless of their ability to pay. As a result of the Medicaid unwinding, we've seen a substantial growth in the number of people without insurance. So we're requesting $8 million for fiscal year 2026 for the CMHC contract funding, and then are also requesting that the proviso that has been in previous years, and in fact, Andy just mentioned it, and to increase the cap on the transfer from the lottery to KDADS, we would request that the committee make sure that the proviso is in the budget again. So with that, Mr. Chairman, I would stand for questions at the appropriate time and appreciate the committee's time.
Kyle, thank you very much.
Thank you, Mr. Chairman.
Okay. Next, I have Patrick Schmitz, the president and CEO of the Burt Nash Center.
Thank you, Chairman Bueller and members of the committee. I'm Patrick Schmitz. I'm the CEO of the Burt Nash Community Mental Health Center. We are the CMHC and Certified Community Behavioral Health Clinic for Douglas County, which we have been serving for nearly 75 years. I'll refer you to my written testimony. I'll just give you the high-level overview. Since becoming a CCBHC, so compared 2020 to 2024, we are now providing 2.5 times the number of services than we were before becoming a CCBHC. Last year, we served 6,142 individuals and provided 163,000 services. In 2024, our mobile response team provided 1,670 services, offering immediate support to those in the community right where they were at, and we're able to stabilize them in their place of residence or their place of business. And our crisis intervention center served 1,582 people, saving many lives in the process. In collaboration with the Douglas County Sheriff's Office and the District Court, we also have established a local competency restoration program, allowing for individuals who are housed at the Douglas County Jail to have their competency restored locally rather than having to wait to be placed at Larned or Osawatomie. And finally, in collaboration with the 988 system as an enhancement to our crisis system of care, we've been able to more quickly get people connected to crisis services, either through the 988 center or in collaboration over to our crisis center or our mobile response team. The CCBHC model has been significant for us, as Representative Ballard can attest. But 53%, by allowing us to cover the cost of 53% of the services. However, 47% of what we provide is to the uninsured or underinsured. And this is where the state mental health block grant dollars are significant for us. It allows us to continue to make access to services available. And then, of course, as Kyle said, the support for the crisis intervention centers are critical for us, both in Douglas County, but the expansion of them across the state, as well as continued support for 988. So with that, I'll stand for questions at the appropriate time. Thank you.
Patrick, thank you so much. Okay, we're going to move on to Randy Kallstrom, President and CEO of the Wyandotte Behavioral Health Network. Randy, welcome.
Thank you, Mr. Chair. Thank you, committee, for being here today. I'm going to hit the highlights of my testimony as well. We became a CCBHC, a Certified Community Behavioral Health Clinic, in May of 2022. And we've been able to enhance and expand our services beyond what we've ever done before. A key component of a CCBHC is holistic integration of healthcare. We developed a relationship with a local FQHC where we successfully connected 473 individuals to primary care that they had not received before, and in turn connected 206 people from the FQHC to us for behavioral health care. We also developed a mobile crisis response team similar to Burt Nash, and last year we provided MCR to over 190 individuals in the community. And our relationships with law enforcement and the justice system in Wyandotte County, which we've had for a number of years now. We have 3 co-responders embedded into law enforcement and responded to over 760 calls to 911 for mental health crisis. Our Crisis Stabilization Center, RSI, served almost 2,000 individuals in 2024, with over 300 of those brought by law enforcement as a diversion to jail or going to Osawatomie State Hospital. Last May, we became the 988 call center for Wyandotte County and received over 4,400 calls, 4,400 calls to our crisis line. As has been said before, the CCBHC has helped transform the services, and we have reduced our turnover rate by 25% and increased our overall services to over 8,000 individuals a year. However, that is only reimbursed for Medicaid. Less than 50% of our patients have Medicaid, and that's the only payer for many of the services we provide. A full 38% are completely uninsured. So without the contract dollars that we receive through the state, doing what we do would literally not be possible in order to be able to provide services to everybody. And I will conclude my remarks and stand for questions at the appropriate time.
Very good, Randy. Thank you so much.
Thank you.
Next up, we have Steve Durkin, the Chief Executive Officer of the Guidance Center.
Good afternoon, everyone. My name is Stevie Durkin. I am the Chief Executive Officer of the Guidance Center, a certified community behavioral health clinic that serves Atchison, Leavenworth, and Jefferson County. I kind of have a unique little perspective here, having worked at the Guidance Center 7, 8 years ago, fresh out of grad school, and then left to go to the federally qualified health center side for 7 years as a CEO. Coming back to the Guidance Center now is like seeing a brand new organization. So much to what Randy and Patrick have already spoken about, it's a completely different organization in terms of the amount of services that we're able to provide, but a lot of the same needs remain, specifically for those that are uninsured. So a couple that I just want to hit on, again, because I'm coming at the tail end of a lot of similar points. The Guidance Center operates, like I said, Atchison, Leavenworth, and Jefferson County. In Leavenworth County, we have the Guiding Lights Crisis Center, which is a crisis stabilization unit. That unit opened in February of 2023, provides supportive therapeutic services designed to find appropriate placement for individuals that need it, reduce emergency room stays or law enforcement contact. While this is a new program and growing, and we're still working on kind of collecting more of our data, we know that we provided over 270 individuals crisis stabilization services that amount to over 631 visits. 85% of those individuals, our data is telling us, are uninsured. So in order to keep that service available to our community, that's something that we certainly want to do. But these block grant funds absolutely help us to continue to do that. I did want to just briefly mention, because I kind of skipped over this, this crisis stabilization unit also serves Donovan, Brown, Jackson, and Nemaha County. Additionally, we are also a couple services that have really gotten my attention as I come back into the community mental health center system. Individual placement and support services. We are helping individuals find sustainable long-term employment. We have had a growing team within our organization find people stable employment, and we're growing that team, and the wait list is absolutely down to 0. However, what we know is when we add the appropriate staff, those referrals are going to come back. So we're working very hard to find sustainable employment for people. And the other really important collaboration, and Patrick kind of mentioned it too, is integration and coordination with local law enforcement. We've got jail liaisons placed within our county jail. So Sheriff Andy Dedeke has been a big proponent of this program, helping align people with needed services before they are released. And additionally, we've got a co-responder model as well in Leavenworth County that we would love to expand into the other communities that we serve. So again, I stand here in support of the legislative priorities of the Association of Community Mental Health Centers of Kansas, specifically increasing the state block grants $8 million to continue to support the impact that we have in our communities. So,
Thank you so much, and I apologize for mispronouncing your name the first time.
Oh, it's
welcome.
No problem.
All right, next we have Michelle Ponce, Acting Director, Kansas Behavioral Health Center.
Good afternoon, Chair Bueller and members of the committee. I normally stand up here and introduce myself as the Associate Director of the Association of Community Mental Health Centers. That's still true, but I'm here today wearing another hat as the Acting Director of the Kansas Behavioral Health Center of Excellence. We started planning for the Center of Excellence about 1.5 years ago now, and we have been a fully incorporated organization for just over a year. We have a pending IRS application for nonprofit status now, and we pulled together a consortium of over just about 20 behavioral health providers and institutes of higher education. The overarching purpose of the center is to focus on innovative strategies to grow the workforce so that we can increase access to care, and with a longer-term focus on research and practice improvement. We've focused our efforts initially on South Central Kansas, Wichita area for a couple of reasons. One being the large number of committed partners across both the providers and higher education, but also with the new state hospital that was planned to open in just about 2 years from now with its own workforce needs. Last year, the legislature appropriated $5.8 million for the Center of Excellence, and this funding is being used for a number of educational and applied learning opportunities. In my written testimony, I provided a number of highlights of accomplishments from year one, and you'll hear more from the next two conferees. Two I want to highlight to you. We've been able to fund staff retention bonus funding to 19 community and technical colleges for 191 nursing faculty, with the hopes that we can continue to gain more nursing graduates. Also, part of that funding was allocated to Wichita State University to fund 10 scholarships in their addiction counseling program. That program had 0 students before these scholarships were made available. They received more applications than they could fund. Wichita State is also about to launch a PhD program in counselor education and several other bullet points in my written testimony. Looking toward year two, we intend to continue all of these programs, and we have some additional priorities identified, primarily around expansion of psychiatry programs and applied learning opportunities across multiple behavioral health professions. And we're looking for ways to leverage that. There might be some opportunities. We're working with KDHE and KDADS around potentially the opportunity to pull down federal funds. If we're unable to do that in year two, our ask would be twofold. An additional $3.9 million on top of our current $5.8. And also, we believe that there might be $1.2 million unexpended in the current year that we'd like the opportunity to reallocate to some of these new priorities. I want to lastly state that we are using none of the state funding for administrative purposes. The Association of CMHCs is providing all administrative support and will continue to do so until at such time into the future that the center can sustain itself. Lastly, in your written testimony, I provided you a list of the governing board members so you can see the list of organizations actively participating, as well as testimonials for some of those students who received those scholarships. What you'll see there is a common theme of gratitude, passion for pursuing a career in this field, and also the acknowledgement that without these scholarships, they would not have been able to enter the program. Thank you for the opportunity to speak with you today, and either myself or our governing board chair will be able to take questions later. Thank you.
All right, Michelle, thank you so much. We're going to move next to Matt Byerly, MD and psychiatrist.
Thank you, Mr. Chairman and committee members, for allowing me to speak. I'm the acting chair of psychiatry at KUMC Wichita. I'm also, my permanent job is as the Associate Dean for Research. We think of ourselves as one KU. I have 2 points I want to communicate today. One is the Center of Excellence you just heard about is critical in providing us a partial life vest for a worsening crisis that we're facing in the Wichita area regarding mental health. And I want to first start by describing how severe that crisis has gotten. In leadership meetings recently and ongoing, there has been discussions about what would happen if we need to close all emergency and inpatient psychiatric care in the Wichita area. Those have been straightforward, serious considerations. Picture that. You have an adolescent child who has a serious overdose attempt at home. You drive to the ER as a parent and you're stuck. We literally had discussions about what would that look like? What would a closed ER look like? What if you have officers in the community who have been brought to assist someone who's severely psychotic and actively dangerous to themselves and others. Where do they bring that person for help? How did we get here? We have essentially one provider for emergency and inpatient care in Wichita. It has had an equivalent of 6 psychiatrists. That care system requires that psychiatrists deliver the care. In the last 7 months, we've lost 3 equivalents of those 6. And of course, the 6 was starting at an underserved care level, barely making it. That's the situation we're in. The lifeline that the Center of Excellence provides is funding more psychiatrist specialists through child and adolescent psychiatrists and for a new program in addiction medicine. And the Center of Excellence's assistance has been the most important positive support factor for our department. But I'll just close by saying we are in a true crisis there, and we have to be thinking collectively about how to safeguard what is potentially close in front of us.
That is kind of a scary environment. Thank you so much.
Thank you.
Okay, next we have Dr. Jessica Provinces.
Provines.
Help me again with that.
Provines.
Provines, oh.
Yeah.
Irish, right?
Yes, actually.
Oh, okay. Doctor, welcome.
Thank you, Representative Chairman and the rest of the committee for allowing me to speak to you today on behalf of continued and increased funding for the Kansas Behavioral Health Center for Excellence. As my colleague, Dr. Byerly highlighted, we truly are in a crisis. And this center is bringing together an unprecedented amount of subject matter experts to figure out how do we train our way out of the workforce crisis. We have to grow our own. And I can speak personally because I am a grown own. I started at Wichita State University over 20 years ago and had experienced my own depression, which drew me into the field. And I worked 3 years unpaid practicums at the counseling center before I was able to get hired on as faculty. And part of my passion is to train the next generation of workforce. There have been numerous nights where I have stayed up crying as I lose one staff member after another, as colleagues leave to go to paid private practice. And I think, how in the heck are we going to keep these training programs going? Not only is it hard to recruit and retain staff and to compete with private practice pay, the work is also difficult. It is traumatizing. I have lost 3 students in my care to suicide, and there have been days where I have wondered if I could continue to do this work. I've thought about leaving, but then I've thought, it's not just my patients, it's not just my clients. It's the students that we're training. I've seen training programs close at multiple centers across the country and across Wichita and our state. We have to invest in growing our workforce. This model is taking It's being modeled after other models that are successful. At Wichita State, we've done a great job of paid applied learning for our aircraft industry. Now we're applying that model that has worked in that industry to behavioral health. This funding is critical, and it has made a huge difference. This is the first year that we have been fully staffed and have had no turnover and have been able to pay all of our students traditionally in the past who had not been paid before. So I urge you, it's important. We're just planting the seeds. We need to continue growing this or it will have devastating consequences. And I think that we are starting on a right path. And I want to thank you for initially funding the project and seeing it forward to fruition.
Doctor, thank you so much.
Thank you.
Next, I have Allison McCain and Whit Downing, Kansas Council on Developmental Disabilities.
Hello. Good afternoon, Chairman Bueller and members of the committee. I'm Allison McCain. I'm the Deputy Director with KCDD.
And I'm Whit Downing, Vice President of Policy and Programming.
And our mission is to empower individuals with IDD and their families to lead systems change and advocate for communities where everyone belongs and thrives. First, we want to start by thanking the Kansas Legislature for reducing the IDD wait list and funding 500 new slots and bringing that cap down to 4,800. While this progress is encouraging, there's still a lot of work to be done to bring that wait list down to 0.
Before gaining employment with the council last February and starting full-time in November, I spent 8 long years on the IDD waiver waitlist. While I now consider myself fortunate to have a fulfilling and accommodating career at the council, the years that I spent on that waitlist were some of the hardest of my life. I experienced more psychiatric hospital stays than I can count or even remember. I survived a suicide attempt. I wore my family out emotionally and physically as they tried to help me navigate a world that often felt unaccommodating and overwhelming. There were times when my meltdowns led to the cops being called on me and me ending up in the back of a police car, not because I was a danger to anyone, but because I lacked the proper supports that could have de-escalated me. I spent countless hours sitting in emergency rooms waiting for help that often fell out of reach. Proper funding for waiver services does not just improve lives, it saves them. It gives people with IDD and their families the chance to thrive rather than just survive. I'm here to advocate for change. The wait list is far too long, and the consequences of waiting are devastating. Because of my new full-time role, I'm in the process of giving up my government benefits, paying taxes, and getting a retirement account from my employer. I'm grateful for the progress I've made and the opportunities that I now have, but I'll never forget what it felt like to be stuck on the wait list. I share my story because I want to be part of the solution. We need more funding, we need more support, and we need more self-advocates stepping forward to share their stories and to push for change.
KCDD strongly encourages the following 3 strategic investments: adding funding for 500 new IDD waiver slots in fiscal year 2026, ensuring that the community supports waiver starts on time during fiscal year 2026, and serves 1,500 individuals by 2029. We also recommend active management of the Kansas IDD waitlist with a management system and technology by adopting a budget proviso for a new KDAD's RFI.
Thank you. We'll stand for questions at the appropriate time.
Thank you so much. Thank you. Next, I have Jawanda Mast, parent and advocate. Welcome.
Thank you, Chairman Bueller and committee members. I appreciate the opportunity to speak before you today. My name is Jawanda Mast, and I am a parent and an advocate for individuals with intellectual disabilities, including my own daughter, Rachel, who is 25 and has Down syndrome. I want to echo what Whit said. We need more of our self-advocates and individuals with disabilities here testifying. And my daughter would be here, but she's at work at the University of Kansas Hospital, which I think is a great reason not to be able to testify. Today, I'm going to sound a little different than some of the others who have spoken because I believe it is time for us to move forward with these reforms. I'm going to mention 3 things and then deviate from the testimony I wrote here to share something. Today, I urge you to support 3 things. Do not slow down the long overdue reforms to the Kansas IDD system. Remove the redundant $20,000 cap on the community supports waiver, and move forward with the proposed conflict of interest changes required by CMS. My family moved here 16 years ago from Memphis, Tennessee, hence my accent does not come from South Olathe, but from the South. We moved here in large part for the promise of better services for adults. My daughter was only 9 then, but we knew we had to move because of wait lists and such. We got here and learned very quickly there were many, many issues, starting with the basis assessment, which is humiliating, outdated, and to my knowledge is only used by the state of Kansas. Yes, you can tell I feel rather strongly about this because it had my daughter in tears the last time she had to sit through it, and some of you heard her testimony on committee. When you have time, I want you to take 2.5 minutes, please, and listen to the testimony that I included, her video testimony before the IDD Modernization Committee about the basis and other things that she needed to be able to live her life fully. Rachel also testified 9 years ago yesterday before another legislative committee on the Kansas ABLE Act. We passed that, and she opened the first Kansas ABLE account. Rachel lives a full life, but she cannot live her fullest life until some of these changes that we have been advocating for many years and have been vetted by many parent advocates, and those that she cannot live her life fully until some of these changes come about. I would just ask you to please move forward with the reforms and the things I've mentioned, and you can read my testimony for more details on that, and I will stand for questions when appropriate. Thank you.
Thank you so much, Jawanda. Committee, that link is in her testimony. Next, I have... All right, next is Mike Burgess, Director of Policy and Outreach, Disability Rights Center of Kansas. Welcome.
Yep. Well, howdy, Mr. Chair and members of the committee. Excuse me. So I will jump through. You have my testimony. I will definitely not be reading it for you, and I've appreciated the opportunity to talk to most of you ahead of time a little bit about the waiting list and the progress and our analysis, and obviously it's really exciting to think about the fact that we went from where we were last year with 5,407 people to 4,320 as of this month, thanks to the efforts previously to add 500 slots. As we looked at that analysis, just kind of give you the Cliffs Notes version, when you have a waiting list that's so long and everyone's encouraging people to sign up early, it's not surprising that when we, through the waiting list study, able to do an analysis of the ages of people on the waiting list, that a lot of people are signing up early. So the number that we need to get there and the path to get there is on the sheet I've attached to this. Because it's really, if we ramp up to about 25, add another 2,500 slots through the 500 this year on the comprehensive waiver, beginning to ramp up the community sports waiver, we can get to that magic number. The third piece of that is rethinking the way we manage the waiting list and doing active waiting list management, which is one of the other conferees talked about as well. We can get there. We can do this. We don't want to see ourselves move backwards. When Chairman Carpenter talked about the idea of the cap, like that, I was first kind of taken back a little bit initially, but it's genius. I mean, it ensures that we are not going to move backwards. And so I want to encourage you to continue that progress, reduce that cap. That with the waiting list now at 4,320, if we add another 500 slots, we could reduce that another 500 and ensure we continue to make progress and get that to zero. So to jump just kind of through a couple of other items to talk about, on page 2 of my testimony, the specific appropriation requests are there. I won't highlight those, but please consider those. And good news on the PD waiting list front. Last year, I think it was 2,400 roughly. They're down to about 1,100 now. From what I've been told, they're going to be able to offer, they should be able to make offers to everyone else remaining on that waiting list. Hopefully that happens. And want to encourage you to continue to do that. And again, we also support the modernization efforts. I've been at DRC 10 years. A number of these things like the MIFI, conflict of interest, those things were talked about before I got to DRC. So it is time to continue to move forward. I think we've got room on the implementation. You know, some of that needs to be worked through, but I do want to urge support of that. And then the cap on the community sports waiver is a cap on a cap, and I'd be happy to talk more on that later on as well if anyone has questions. So with that, Mr. Chair, I'd be happy to stand for questions at the appropriate time.
Thanks, Mike. Appreciate it.
Thank you.
All right. Next, I have Leslie Anderson, Executive Director, Kansas Association of Area Agencies on Aging and Disabilities. Leslie, welcome.
Thank you very much. And thank you for the opportunity to testify on the KDAD's budget. As you said, I am Leslie Anderson. I'm the Executive Director of the Kansas Association of Area Agencies on Aging and Disabilities. I represent the 11 area agencies on aging that serve all the counties in Kansas and probably a lot of your constituents. I'm going to be very brief with my comments because you have my written testimony. There are 3 requests in our testimony. And to give you a little background, the area agencies on aging provide and also broker services for Senior Care Act, the nutrition services for older adults, and then the Alzheimer's disease respite program. So we're asking with the Senior Care Act an additional $5 million. And that is really based upon the providers who also provide HCBS services of personal care and other in-home services are negotiating higher rates for Senior Care Act. And in some instances, those are $5 more per hour. That's a lot of money. Also, in order for AAAs to be competitive with compensation packages to recruit and retain case managers and other administrative staff, that additional money will be needed. Secretary Howard talked about the nutritional services for older adults yesterday and the cut that came down from the feds. And so the governor's budget has $1 million in that. We're asking for $3 million. The reason for that is the rising costs of food, paper goods, provider costs, fuel, and a growing wait list. So we ask you to add a total of $3 million in the budget. We are also requesting the continued funding to grants to the area agencies on aging that cover the Alzheimer's respite program and also the core funding that assist the AAAs with managing their programs and staff that are not program specific, like I mentioned before, the Senior Care Act and Older Americans Act. And with that, I will close and will stand for questions at the appropriate time.
Leslie, thank you so much. Next, I have Lynn Dalrymple, she's a nurse, area director for Thrive Skilled Pediatric Care. Welcome.
Thank you for having me today, Chairman and board members. My name is Lynn Dalrymple. I am the area director for Thrive Skilled Pediatric Care. What we do is provide life-sustaining nursing care to medically fragile children that are on the TA and the IDD waiver. Our ability to provide this specialized medical care for those children in the home directly offsets the care and the cost of those child being in the ICU, NICU, and PICU. We are not a contract staffing nurse agency. We're private duty nursing, where we hire the RNs and the LPNs and train those RNs and LPNs on how to care for these children in the home. As you can imagine, that is quite the cost, but it is still much cheaper than what we do when we're in the hospital for the $12,000 a day. Okay? We do have two asks. Our first ask is to please rate an increase from 50 that we currently have to 55 for the next year. And then we also ask that you fund the TA waiver capacity increase requested by KDADS and funded by the governor so that we do not create a waiting list for either one of these, any of these children that have specialized medical care. What we do every day is keep them alive. They are on technology every day to stay alive. They just cannot be on a waiting list for that reason. We do appreciate the modified increase to $50 passed last year. However, the request was for $55. If you look at the updated Mercer market rate study that was done in Missouri, the lower rate range is $55.96 or $56 an hour, and the upper range was $70.28. So the Missouri right now pays $61. And in the Overland Park and the Kansas City area, you can imagine that a lot of our nurses are going over to the other side and getting that increased rate, doing the exact same thing that we need them to do here, you know, in Kansas and the Overland Park area. At one point, the specialized medical care program was unable to serve many of the children that needed this nursing care. But due to the increases that we've had over the last couple of years, that has vastly improved. What we have right now is that we still have the need for weekend and nighttime nursing. We got the day shifts taken care of, but we really still need to work on getting those difficult rural cases in the middle of nowhere. And that means that we are with the competition of the nursing and the hospital there that can pay a lot more. So we just really ask that you think about that in the budget for next year. All right. Thank you.
All right, next I have Amy Campbell from the Kansas Mental Health Coalition. Welcome, Amy.
Thank you, Mr. Chairman. My name is Amy Campbell. I work for the Kansas Mental Health Coalition. The coalition is a roundtable organization that comes together to develop a consensus agenda for the things we advocate for. I've visited with most of you one-on-one and talked about the importance of the behavioral health continuum of care. In 2018 and 19, we had the Mental Health Task Force reports that developed a strategic plan for the state of Kansas to improve a mental health system that was crumbling. We had people waiting way too long for hospital beds. We had people that could not get community-based services that were needed, and the mental health crisis kind of went up from there. From that strategic planning, the legislature has worked to fund filling the gaps in that continuum of care. And you have heard different representations of that continuum today. The CCBHCs, the state hospitals, the community hospitals that offer psychiatric care within their units. On these notes, I would like to point out that we need to restore the reappropriations for the state hospital electronic health records. We support the agency's request for state institution building funds for projects going on within the state hospitals that are absolutely necessary for the capacity that we need there. Additionally, you've heard from 988. You've heard from the CMHCs about the mental health grants funding for the uninsured and the request for the Behavioral Health Center of Excellence. I don't think that I could say that any better than the folks you've already heard from. Please expand the cap on the lottery vending machine funding for the crisis centers and the clubhouse program funding. And please also look at the issue of state employee pay. At the end of the day, we also have the MHIT program for K through 12 mental health. This committee might like to have a briefing on that from KDADS. It's a very important program that should be expanded. And with that, Mr. Chairman, I would stand for questions at the appropriate time.
All right, Amy, thank you so much.
Thank you.
All right, next we have Kylie Childs, Director of Government Affairs, Leading Age Kansas. Kylie, welcome.
All right. Thank you, Chairman and members of the committee. My name is Kylie Childs, Director of Government Affairs with Leading Age Kansas, which is the state trade association of nonprofit and other mission-driven aging services providers. So first and foremost, we are grateful to the legislative body for the last couple years for continuing to place residents and providers as a priority when it comes to funding and come again before you requesting assistance to ensure we don't move backwards. As most of you have heard from me at this point, we are at a critical point where we have more seniors aging 65 and 85 plus and in need of services, and we are seeing a decline in the availability of those services. Some of these closures are the result of financial strains due to rising costs, the regulatory environment of aging services, and workforce challenges. And I would like to note we do have some frontline CNA staff here with us today, and I'd like to thank them for all they're able to do for our aging Kansas. There are some more details on each of those challenges we face, but I won't go into those with you today. They are in my testimony. For our nursing facility requests, Governor Kelly and KDADS did fail to address the statutorily required rebase for nursing facilities in the recommendations for fiscal year 26. So what is currently in HB 2007 only includes a 3.75 inflationary increase for providers. And so to comply with the law, we would request 4.8 million state general funds be added to HB 2007 to complete that rebase. In 2023, the Kansas Legislature's Special Committee on Nursing Facility Rate Methodology recommended continuing the Medicaid capacity payments to help providers achieve at or near 100% cost reimbursement and stabilize services. In 2024, providers face another rate change with the transition from resource utilization groups, or RUGs, to patient-driven payment model, PDPM, as directed by CMS. So until we can review rate methodology recommendations with KDADS and ensure PDPM accurately reflects resident acuity and costs, we would request the following for the Medicaid capacity payment in fiscal year 2026. 40.9 million state general funds for a $30 per Medicaid resident per day add-on. As the association that represents the full continuum, we believe we should fund it accordingly and allow seniors to age where they wish whenever possible. So we learned from KDADS this month that the HCBS, or Home and Community-Based Services Frail Elderly Waiver, has continued to see increases in caseloads and participation, which shows that the efforts that the legislature has made over the last few years are paying off. So to prevent a wait list resulting in delays in health services, unnecessary nursing facility placements, and adverse health impacts for aging Kansans, we would request 6.3 million state general funds to accommodate the increase in caseloads for the HCBS FE waiver. For the PACE program, the PACE philosophy, or Program All-Inclusive Care for the Elderly, is centered on the belief that it is better for frail individuals and their families to be served in the community whenever possible. When Care first started, the state decided to treat PACE as a fourth MCO provider, and PACE is supposed to be paid at 90% of the capitated rate that Kansas pays their MCOs. As costs continue to rise, it is more important than ever for these providers to be rebased and prevent costlier nursing home level care and allow Kansans to choose where they receive services. However, without this directive from the legislature, KDABS is unable to complete this rebase. So for these reasons, we would request proviso language being added to HB 2007 to ensure KDABS completes this rebase, aligning payments to 90% of the amount otherwise paid, or AWOP. And there is language on page 3 that we would request. Page 4 is a summary of all our requests, because I know I went through things a little quickly today. I will stand for questions at the appropriate time.
That was very quickly. Thank you, Kylie. Next, I have Deborah Factor, the Chief Executive Officer from Youth Corps Ministries. Deborah, welcome.
Thank you. Thank you, Chairman and committee. Nice to see all of you. I am here to ask for a second year for a $350,000 grant to continue to expand our work. We are a grassroots movement focused on mobilizing communities in very rural towns to solve poverty. Your grant last year, we're still in the middle of that, but we've done some additional hiring. We've increased our capacity. And for the first time, we're strategically trying to grow. Our commitment is try to develop core community in every county in the state of Kansas. And I just want to share with you real briefly what we've done since I was here last year. We have launched in 2 new communities, Ulysses and Abilene. Our graduates, we've graduated another 114 individuals who are struggling in poverty. We've impacted another 129 kids. We have 56 more out of financial poverty, defined at 200%. Our graduates have increased their annual income with us by another $1.2 million annually, with a total of $5.8 million annually income increase since joining our program. Graduates have also decreased their welfare assistance another $57,000, with a new total of $307,000. Our fourth quarter numbers are still coming in. Welfare has dropped another $15,000 since October. We are just feel convicted that we know how to solve poverty, therefore we must. We're asking you to continue to help support us to expand across the state of Kansas. We're also intentionally working right now to launch in 3 new communities.
Deborah, thank you so much. All right, next up we have Dr. Janet Williams, CEO of Minds Matter. She's coming from the back room. Janet, welcome back.
Thank you. I was in the DMV room waiting for my number to be called. We were saying, like, you should just give everybody a number, and then you just have to call the number, and then we come up and give our name.
That's a process improvement.
Right?
Yeah.
Because I am all about process improvement. We're going to talk about that today. So I am here to talk about the brain injury waiver. I was here on Tuesday. You have my written testimony. It is posted online. And one of the things that I realized when I testified on Tuesday is we have a lot of new members on this committee. And so I just wanted to briefly tell you about the brain injury waiver. So it is the first waiver in the country specifically for people with brain injuries. A waiver means that if a service can be provided in an institution, we get a federal waiver to provide those same services in the home and community. In the 1980s, the state of Kansas had 6 people out of state. It was $300,000 per person out of state. And when the state would call and say, how is Joe doing? They would say, he's fine, and send him back to the state hospital or a nursing home. This group came together. I was not here at the time, and developed this waiver, and they've not had to add any services to it in all the 30-some years that it's been going. It's really, really successful. The thing that is different about this waiver than other waivers is it's a rehabilitation waiver. It's temporary. People are not on this long term. For my company, the average amount of time is 1.9 years. And so you go in, you do the rehabilitation, you ask people their goals. The other beautiful thing about this waiver is everyone is in their own home. Agencies do not own property, and you are not paying for people's housing. They're paying for that out of their SSI or their SSDI. So that's a huge cost savings when you think about it to the state of Kansas. And so when someone is done with the brain injury waiver, they then transition to the physical disability waiver, the frail elder waiver, or the IDD waiver. It is their choice, and they work with their MCO to decide which MCO. Only 2% of people on this waiver go back to any kind of facility, whether that be a group home or a nursing home. Those are huge, huge numbers, and it's just a great success story. So when someone is screened and found eligible for the brain injury waiver, they can choose a brain injury rehab facility, which is called a BIRF, or they can choose to come directly onto the HCBS program. The legislature increased the rate for the BIRF to $1,400 a day. People stay there an average of 18 months. For 1 year at the BIRF, it costs $511,000 per person. On the brain injury waiver, it's $99 per day. It's $36,000 a year. So as soon as someone leaves Meadowbrook and goes to their own home, you are decreasing by 14 times the amount of money. So we can serve 14 people in the community for serving one in the brain injury rehab facility. Brain injury rehab facility is a Medicaid state plan service. So it's automatic. The HCBS waiver is something that you qualify and can have a waiting list. We've really done a great job not having a waiting list, but 18 months ago, KDADS realized that there were over 800 authorized hours per week that were not being filled. They brought us together, the MCOs, and there are only 3 or 4 providers for this program, and said, what do we need to do? We said the rates have not been increased in this amount of time. We renegotiated our rates with the MCOs, and as of last week, we had fewer than 100 hours per week that were open, compared to 800 hours per week 18 months ago. And so those renegotiated rates obviously worked, and the turnover rate went from 20% down to 2%. And we're also getting people off faster because now we have more therapists. So when you have 800 open hours a week, that means people aren't getting the rehab they need. They're staying on this program longer, right? So you heard on Tuesday that Sunflower State Health Plan on December 3rd decided that they wanted to cut our rates by 20%. Those are our negotiated rates, and said we would like you to go to the state and get a rate increase. This is the first time in many, many years that I've asked for a rate increase, because I was always here saying we can't have a waiting list on this program. The governor has allocated money in her budget for the waiting list, and of course I strongly advocate to not have that, but I'm telling you, if you don't increase the base rate, then you're going to get an 800-hour-a-week waiting list again that is not as visible. So right now, the rate is $18.99 per unit. Missouri has the exact same waiver that they just started, and it's $30 per unit. Nationally, it's $35 per unit, and we're asking for you to recommend $30 per unit. That's it.
Can I gently nudge you on, or did we?
Done.
Oh, okay. That was the mic drop.
Isn't this what you do with the? So, thank you very much. I appreciate your time.
Thank you so much. Okay, let's move on then to Dan Goodman, Executive Director, Kansas Advocates for Better Care. Welcome.
Thank you. Thank you for the opportunity to testify. I'm Dan Goodman, Executive Director of Kansas Advocates for Better Care. Kansas Advocates for Better Care is dedicated to improving long-term care for older adults. And we respectfully request funding and your support for a statewide resource guide for older Kansans. This initiative was recommended by the Senior Care Legislative Task Force, and it would create a statewide resource to improve long-term care information. It's modeled after the Douglas County Senior Resource Directory. It would fund a sustainable platform, a statewide print distribution, and an up-to-date online version. This investment will empower older Kansans and their families to meet essential information support independence and provide better outcomes. Additionally, KABC supports key KDAD's budgetary items and the Alzheimer's Association's request of licensure requirements for assisted livings offering memory care to ensure transparency and appropriate services for Kansans. We appreciate your leadership in strengthening care for older Kansans, and I will be available for the questions. Thank you.
All right, Dan, thank you so much. Okay, I don't see her, but Linda Mowbray, oh, there she is. Linda Mowbray, President and CEO, Kansas Healthcare Association and Kansas Center for Assisted Living. Linda, welcome.
Mr. Chairman, thank you. Committee members, thank you for having me here today. So Kansas Healthcare Association, Kansas Center for Assisted Living is a trade association that represents nursing homes, assisted livings, home plus, residential health care. If you're not familiar with our settings, let me know, and I'll be happy to provide a little cheat sheet with acronyms on there. It's full of them. We had a crisis in our nursing homes just a few years ago. Pandemic related, yes. Staffing shortages, all kinds of funding issues, costs. 26 nursing homes closed in the state of Kansas. Over 1,000 beds were lost. And those beds were somewhere in rural Kansas, sometimes in urban areas, but always in areas where there was an economic impact. There was a social impact. There was an emotional impact. Residents, families, staff losing their jobs when the nursing homes closed. You all heard us, or for some, your predecessors heard us, and helped the nursing homes by creating a Medicaid add-on of almost $20 a day to help stabilize the nursing homes. And that helped. That first year that we had the $20 a day, we did not see any closures. Last year, the funding was not quite as available, and the add-on was dropped down to $15 roughly per day. We're back on shaky ground. In the last year, Life Care Center of Osawatomie, Medical Lodges Oxford, KC Promise of Overland Park, Homestead of Emporia, and a new in Horton have closed. There are 11 nursing facilities currently in an extreme risk to close, and there are 7 nursing facilities that are at a high risk to close. Based on the 2023 cost reports, 43% of Kansas nursing homes were operating at a loss. 43%. And when the cost of eggs goes up, grocery stores can raise their prices. My favorite place for breakfast in Topeka, raise their prices 20 cents an egg when you have breakfast. We can't do that. Our prices are fixed by federal and state. I would ask you to consider the proposal that we have. The numbers are big, but in all reality, it's 18.4 million state general funds more than last year's budget. It's a lot of money. But how much does it cost to close those nursing homes and not have capacity in our towns? I also would ask you to consider our request for HCBS. The frail elderly waiver is keeping people in their homes in assisted livings, and it's doing a great job. Exactly what it's supposed to. But we're at risk of having a waiting list on that as well. I'll stand for questions at the appropriate time. Thank you so much for your attention this late in the afternoon.
We are getting there. Linda, thank you so much. Okay, I see her in the back. Casey Dahlke, Executive Director, Children's Advocacy Centers of Kansas. Welcome again.
Thank you. Good afternoon, Mr. Chair, members of the committee. I am Casey Dahlke, Executive Director for Children's Advocacy Centers of Kansas, a network of 18 child advocacy centers that coordinate child abuse investigations in communities. I am here today to address problematic sexual behavior, a growing concern of youth, our youth that we see. Left untreated, problematic sexual behavior can lead to severe consequences for kids, families, and communities. The consequences that I would like to highlight for today's testimony: increase of juvenile delinquency, incarceration, and then, of course, children being removed from their home, placed into foster care. And as we could imagine, children with problematic sexual behavior are not able to maintain a steady foster care placement. They bounce around from foster home to foster home without having the underlying cause of problematic sexual behavior treated, and eventually end themselves in a psychiatric residential treatment facility or a PRTF, which I'm sure this committee is aware of the consistently full beds, the expense of a PRTF, and the wait list that follows. Thankfully, child advocacy centers have a solution to this problem. Problematic sexual behavior, cognitive behavior therapy, an evidence-based program out of the University of Oklahoma, is the solution to fix this underlying issue of problematic sexual behavior. Last year, my organization partnered with KDADS to fund a training program. As it stands right now, child advocacy centers are the only centers across the state of Kansas that provide PSB CBT. And with these training dollars that we received from KDADS last year, we aim to train an additional 5 centers this year. This treatment is critical, and I want to highlight just a couple of the high points of a child that receives this treatment. OU boasts a less than 2% recidivism rate. You're going to hear from one of our members today that are currently providing this service that is in fact accurate. Also, when we're talking about family stability, we're planning to keep, with this treatment model, we hope to keep children at home. Our hope is early detection of problematic sexual behavior. They're referred to a child advocacy center. They're able to receive that treatment while still remaining at home without even being removed and placed into foster care to begin with. I'm confident in the OU program. I'm confident in our membership of child advocacy centers to be able to provide this service. When we're able to keep families and kids together, that leads to safer communities as well as less victims from problematic sexual behavior. We wish to continue this work and build on our progress. Our ask to this committee is $1.6 million. I do have the actual dollar amount on the last, I think it's actually second to last page of my testimony, broken out and what it's going to cost specifically to continue these training efforts, as well as sustainable full-time employee dollar amounts for child advocacy centers moving forward. As I said, you're going to hear from 2 of my members right after me. One is currently providing this service, so is going to be able to speak to the need that they see daily, and another that's on the list to be trained this year. With that, I'm going to stand for questions at the appropriate time.
All right, Casey, thank you so much.
Thank you, Mr. Chair.
And so if we're going to go next is Judy Rodman, President, CEO, Sunflower House. Welcome, Judy.
Hello. Thank you. I'm a little short here. Thank you, Chairman, and thank you, Committee, for having me here today. I'm very excited to have this opportunity to share with you about our experience in providing problematic sexual behavior, cognitive behavioral therapy to our communities. So Sunflower House is the child advocacy center that serves both Johnson and Wyandotte counties. Early on, when we started looking at the needs of the community, we knew kids with problematic sexual behaviors was an area that we needed to address. So we partnered with our multidisciplinary team, which included law enforcement, Department of Children and Families, Mental Health, and Children's Mercy Hospital to talk about this need. In 2020, we launched the training program. So in partnership with PACES of Wyandotte Behavioral Health Network, the therapists started their training session and started receiving clients in 2021. Since the start of our program, as you can see in my report, we have received 190 referrals for our program, and we've had 47 kids that have graduated the program. Similar to what Casey just spoke to, we have a 98% success rate with kids that have completed our program. Out of the 47 that have completed, we only had 1 child that went out and reoffended. I want to point out the 55 kids that dropped out of services. Those kids that dropped out of services, similar to what Casey had just spoke about, 29 of those kids were involved in foster care. And so once they were removed from their home and sent someplace else, they were now out of our catchment area to be able to provide those services. So by having other child advocacy centers throughout the state that is able to provide this treatment, it's critical because then that child is not constantly starting over at intake and assessment. We could collaborate together, and if they're on session 3 at Sunflower House, and then they go to another center, they pick up where they left off, and treatment is able to continue regardless of where their placement is located. Some of the other important information that I think is that we should know about is we had 70 kids that did not qualify for our program. Out of those 70 kids, some were out of range. Out of the age range for our program. So currently the program that we offer for problematic sexual behavior, CBT, is ages 7 to 12. And so with an expansion, we would love to be able to have clinicians be able to be trained to be able to provide the program for adolescents as well. Some of the families that refused care were also families involved in our foster care system. So we would love to have a commitment from our partners over at DCF that if a child is placed with a caregiver in foster care and this is an issue, we would love to have them commit to being able to send those kids through treatment. And looking back over my data over the last 3 years, I saw one family that initially declined and then came back 2 years later, finally ready for the program. So we know that there has to be a commitment. This program, it requires both the child and the caregiver to participate because both have to be able to make changes for this child to be successful. So one of the things that we looked at is early on, we talked to our MDT team, and most of our referrals came from the Department of Children and Families, which was great. But one of the things that we've done at Sunflower House is we have engaged in memorandums of understanding with all of our public schools. And so we go out and provide prevention education from preschool through high school and through adults in the school system. And so we address personal safety, body autonomy, and e-safety. So one of the things we learned from problematic sexual behavior is the majority of the kids that we serve, this started out due to early exposure to pornography. So through this training, we know that the average age of accidental exposure to pornography is age 9. So it's critical. So one of the things we started looking at is why are we waiting until we get referrals from DCF so this child had to offend before action takes place? So we started providing some training to some of our school social workers and counselors on PSCBT, and we've started receiving some, some referrals from schools. And so that way we're able to get them even earlier before offending and to be able to address the behaviors. And through this training, just that collaboration of bringing those school partnerships in place, we think is absolutely critical. So thank you for your time today, and I will stand for questions when needed. Thank you.
Judy, thank you so much. My mic was off. Next, we have Bryn Murphy, CEO, Sunlight Children's Services.
Good afternoon. Thank you for the opportunity to speak with you today. My name is Bryn Murphy. I'm the CEO of Sunlight Children's Services. Our organization is committed to providing resources and facilities to victims of child abuse and their families. We do this with 2 essential programs in Butler County. We have a CAC, and we also have an emergency shelter for youth ages birth to 18. One of the vital services our CAC will soon be able to provide is PSB therapy services. Based on the funding that Casey talked about earlier, our therapists are going to be able to go through training, and it's something that we're very excited about being able to provide to the families in our community. Today, I want to highlight an urgent need, though, that we see at our emergency shelter. Sunlight is uniquely positioned to provide placement for youth throughout the state of Kansas who are in police protective custody or foster care and in need of an emergency placement. In the past decade, since we've been open, we've served 85 counties in Kansas, and we typically take about 700 youth per year. Last year, about 90% of the youth that we served at our facility did not have access to PSB services. To illustrate the scope of this need, I want to share with you a recent example. This morning, I reviewed a referral from one of the 6 Kansas foster care contractors. This referral was for 15 children in need of immediate placement today. Out of those 15 youth, 7 had problematic sexualized behaviors listed on the referral source. 1 was a survivor of human trafficking that was 17 with a baby. So 9 out of the 15 would have been primary referral clients to a child advocacy center in Kansas. 7 of those 15 are in placement and in need of problematic sexualized behavior. This is not an isolated incident. It's a daily reality for our organization to get referrals for youth who have problematic sexualized behavior, either coming into police protective custody or youth that are in foster care. The need for statewide access to problematic sexualized behavior is undeniable. I don't know what the need is across the state because I don't believe that that data is currently being tracked, but I know for certainty it's an organizational problem that we see every single day, and we have to debate if we can accept these children to our services or not. And we are just one placing agency across the entire state. I urge you to consider the funding for problematic sexualized behavior so that we can have access across the state through all CACs, as Judy said, to follow these children and try to remain in their households, and if they cannot, have those access wherever they are in foster care. Thank you for the time, and I will stand for questions when appropriate.
All right, Bryn, thank you so
Thank
much.
you.
All right, next we have Sean Sullivan, President, CEO, Midland Care Connection. Sean, welcome, and thank you for your patience. We are getting close to the...
You are getting close. Yeah, thank you, Mr. Chairman, members of the committee. There's a very inappropriate betting pool out in the hallway as to whether I can complete my testimony without the time warning started by Kyle Kessler, so I'm going to be really brief. Appreciate the opportunity to talk about two things. I'm with Midland Care. We provide a number of community-based services to Northeast Kansas, Central Kansas, and also Missouri. To mostly older adults. The first thing I want to talk about is PACE, which is one of the 200 acronyms you all have heard about this afternoon. PACE stands for the Program of All-Inclusive Care for the Elderly. It serves people that are 55 and older that need a nursing home level of care and certified by the state to need that. 3, that want to remain at home and in their community. And then 4th, are able to do that with our services. We are one of 3 PACE providers in Kansas. I'm here speaking on behalf of all 3 of them. The first one started in 2002 in Wichita and has a PACE center in Wichita through Ascension Living. The second is Blue Stem PACE in McPherson and Hutchinson with PACE centers there. And then we have PACE centers in Topeka, Lawrence, Emporia, Kansas City, and we'll be opening one in Olathe later this year. As we do every year, we come asking about requesting a Medicaid rate, what's called rebasing. The way that Medicaid rates are set, as Kylie Childs already referenced with Leading Age Kansas, is the state and their actuaries at KDHE, KDHE and KDADS and the actuary submit to CMS every April 1 what the state would pay the CanCare companies, the 3 CanCare vendors, for the populations that we take care of with that criteria. And then they set to PACE providers, here's what that is, minus 10%. So we are to be paid 90% of what the 3 CanCare vendors are, and we come every year and ask for that to be updated every July 1 to keep pace with that, pun intended. So we're through that 10% discount because every person we serve would be in CanCare otherwise. We're saving the state about $5 million just with our program. And we request, again, annual rebasing with the next fiscal year. Second thing real quick on PACE, back when many now years ago when I was with the state agency, this was a program serving about 150 to 200 people. It's now 1,000 plus. And so we support the agency's efforts to continue using consultants to enroll people and work with us to support our program. Second request I want to talk briefly about is the Meals on Wheels and nutrition funding. Leslie Anderson with the Area Agency on Aging already talked about this. One of the things we do is nutrition funding, Meals on Wheels, to about 1,200 people in a 3-county area. We have seen a drastic increase in demand for our services, mainly because of demographics of older adults. And because of the federal cut that was referenced and why the governor included an enhancement request in her budget recommendation, something doesn't get figured out, we're going to put a waiting list for our services and probably around 200 people on top of the 1,200 people that we serve today. So would request consideration for that enhancement request to take care of that waiting list and the federal cut. With that, thank you again for your attention and for the wonderful work you all do, and happy to answer questions later. Thank you.
I think you lost the betting pool, but that's okay. We won't tell them out in the hall. We hope they can't hear us out there. Okay, next we have Rodney Whittington, CASE, Legislative Committees, Kansas Adult Care Executive. Rodney, welcome.
Thank you, Chairman and committee. You've heard from my colleagues from Kansas Healthcare Association and Leading Age. I'm representing CASE today, but I'm also the CEO of Advena Living. We have 9 communities across the state, and as Linda referenced, we have several of our buildings on that highly at risk to close if the funding isn't restored to the $30 a day add-on. In my 26 years of operating in Kansas, 2023 was the smoothest when we had our costs covered, and I want to thank everyone that was involved in making that happen. What we're asking for isn't a luxury. It's simply to be able to stay in business. One of the components that Linda mentioned was PDPM and how that affects our rates is that a lot of our residents these days especially have mental health issues over what their physical needs are. In that calculation, somebody that is able to feed themselves or dress themselves is viewed as easy to care for when they are the ones that typically we have to give the most oversight, oftentimes one-to-one care, if they're in a behavior state where they're causing harm to themselves or others. But that is not recognized in the PDPM calculation, and therefore our rates don't come close to covering our cost for that. But on the regulatory side of that, the expectation is there for one-to-one care, and we are considered endangering them if we can't afford to provide that. Again, those are the main things that I wanted to cover. The rest of the stuff is in the written testimony, and I'll be here for questions as well. Thank you, guys.
Rodney, thank you so much. Did he make it? We have a winner. You made it. All right, Des Martins, President and CEO, Mirror. Des, welcome.
Thank you, Chairman and committee. Appreciate the opportunity. It's nice to see some familiar faces and some new faces as well. Like I said, Des Martins, President and CEO of Mirror. Mirror has been providing addiction treatment services since 1972 to Kansans, their families, and communities. We play a crucial role in serving uninsured, underinsured, just as involved, and Medicaid-enrolled Kansans. And for many, we are their last best hope. We provide outpatient and residential treatment services in multiple facilities across the state. We also provide telehealth and medication-assisted treatment across the state of Kansas to ensure all Kansas have access to treatment. In state fiscal year 24, we served over 4,000 unique individuals, and as you'll see, 49% of those were funded through the block grant funds. We appreciate the legislature's decision last year to allocate increased funds to the block grant and the additional 3.5 for the indigent fund. This enhanced the services so that Kansas could access life-saving treatment. We respectfully request with others that $6 million be added to the federal block grant for state fiscal year 26 and that the indigent fund be continued. In 25, Mirror received funds for a workforce development project to assist us in retaining and recruiting staff. You see, organizations that receive enhanced reimbursement rates were able to pay higher salaries and disproportionately impacted Mirror in workforce issues. The funds were used to improve salaries, expand training opportunities, support practicum students and interns on their path to licensure. They're crucial to continuing our mission, and we're grateful for that support. We respectfully request that $1.8 million be allocated to Mirror in state fiscal year 26 to continue this project. Retaining staff allows us to operationalize 50 more beds in our current facilities and serve more Kansans on the waiting list. In July, Mirror will open a regional adolescent treatment center in Wichita for males and females 12 to 17. Adolescent treatment is needed and scarce. What we're needing is the reimbursement rate for adolescents is $206 a day, which is the same as it is for adults. Adolescents require more. We are requesting that the adolescent treatment rate for Medicaid rate have parity with the adolescent block grant rate for residential treatment for adolescents. This would help us with significantly improve access and sustainability and quality of care for adolescents. Please note the graphic we provided because it has a rationale for a lot of the testimony. Thank you.
Yes, thank you so much.
Thank you.
Okay, moving next, we have Sarah Foreman, Interim Director, Stepping Stone Shelter. Welcome, Sarah.
Thank you very much. My name is Sarah Foreman, and I am interim director for Stepping Stone Shelter in Seward County, Kansas. So that is the western half of the state. I believe we do get the award for driving the farthest, which is often the case, but thank you for having us. In Seward County, we rank the lowest, 105 out of 105 socioeconomically. Our needs are vast and our resources are scarce. At the shelter, we do enforce boundaries before entry. We are a no-tolerance substance abuse shelter. We require picture ID upon admission, and residents are required to seek and sustain employment during their 90 days. In 23 and 24, we house Kansans from 20 different counties in our great state. We aid residents in life changes that will prevent future homelessness by helping them secure childcare, establish employment, locate stable housing, access basic medical care, and GED obtainment. Our kitchen at the shelter is hemorrhaging. Last year, we served 32,000 meals out of a kitchen no bigger than a single-family home. I urge you to look beyond the boundaries of your constituents and see the impact this investment will make across the state. We acknowledge the financial scrutiny that all departments and levels of government are facing. We recognize that our ask is bold, and we ask you to be bold with us. Your belief, your vote yes on this one-time allocation for Western Kansas would make an immeasurable impact on the most vulnerable single parents, children, veterans, disabled, elderly, and those in recovery. You will allow us to keep Western Kansas counties welcoming, safe, and fed. The total renovations for ADA compliance, a commercial kitchen space, and accessible bathroom facilities are just over $1 million. We are actively seeking additional funds to cover the remainder, but today our ask is for $800,000. Please reference the packet that was provided for additional information, and we are available for questions when appropriate. Again, thank you very much.
Sarah, thank you, and thank you for coming such a long way. Yes, appreciate it. Okay, next I have Lori Gonzalez, Ember Hope Youthville.
Good afternoon, or maybe I should say good evening, right?
Close.
Chair Beeler and Vice Chair Carpenter and esteemed members of the committee, thank you for the opportunity to speak about the work we're doing at our Psychiatric Residential Treatment Facility, or PRTF, and especially the work we're doing with our aftercare services. A few years ago, we came before you and asked for funding for a PRTF pilot program. Vice Chairman Carpenter was the chair at that time. Our initial proposal submitted by Ember Hope Youthville for funding the PRTF pilot project was developed to address concerns noted in the 2019 NRI report for the state of Kansas on the use of PRTFs. We received the report, we read it, we created a program with recommendations, and with your financial backing, we've done all of that. We are deeply grateful to this committee and KDADS for believing in our service delivery model. Our approach includes offering 6 months of aftercare services to all clients and families who successfully complete treatment at our PRTF. This essential service exceeds expectations and operates beyond the scope of services of the allowable daily rate. We would like to request $250,000 to continue covering the costs associated with offering aftercare services. While aftercare is not a requirement of the PRTF services, our data demonstrates positive results for youth and families. We have served a total of 59 youth in PRTF aftercare, still serving some of them. To date, we have had 1 youth readmit to a PRTF during that 6 months of aftercare. This data demonstrates the impact of aftercare in keeping youth in their home setting and avoiding readmitting into a PRTF. This is not only excellent for children and families, but also generates significant cost savings for the state through exceptionally low readmission rates. Because of this success, KDADS is actually implementing the same aftercare program with other PRTFs in the state of Kansas. We are witnessing remarkable therapeutic and life-changing outcomes through our program. We respectfully ask for your continued support and funding for this unique service model, enabling Ember Hope Youthville to continue inspiring positive change in the lives of Kansas youth and their families. And in my testimony, you can see there's other testimonials from some of our clients and family members I encourage you to read. So I'm happy to stand for questions whenever appropriate. Thank you.
Lori, thank you. I think our last in-person is Stuart Little, Behavioral Health Association of Kansas. Dr. Little, welcome.
You're happy to see me, I can tell. Good afternoon. I do appreciate everyone's time listening to all of this conversation. That's one of the virtues of serving on this committee, is you probably have a better sense of the needs that exist in this state than any other committee around. So thank you for doing that. My name is Stuart Little. I represent the Behavioral Health Association. Here there are drug and alcohol and behavioral health treatment providers around the state. They're listed on page 2. We've got 10 folks in our organization. I just very briefly wanted to come back to a theme that we've talked about for the last few years, which has been the legislature's contribution of $5-6 million kind of every year added to the block grant pool, which is fits within the federal poverty level. It is managed by Carillon, and KDADS is responsible for making for sure that there's geographic spread and that those block grant dollars are used around the state and wisely. And so I follow up on some of my other peers who have appeared and asked to have that added again. The uninsured population continues to exist. And that's obviously a priority for us. I do note a couple of issues I wanted to point out and note in particular some specific asks to address some providers with workforce issues. Everybody in the behavioral health world has workforce issues, and everybody would enjoy the access to increased salaries, those of us that are not in certified community behavioral health universe. And so if those kinds of things are going to be managed through the budget process, we think there should be some equity involved in the distribution of that. The other final comment I would make is that there has been some confusion. You've heard a couple people come up here and talk about block grant. We need money for the uninsured. Before you make decisions about how to allocate that money, you need to kind of unwind some of this. There's been a tremendous amount of Medicaid money into the CCBHC system, and we still have this uninsured population. So some of the conversation has said, add funds for the uninsured, and then there was some comments made very specifically, add funds for the uninsured to put into contracts for one provider system. That's just going to go to one system. You add these resources to the block grant, those are distributed through the managed care system, and they're part of the broader KDAD's perspective. So I'd be happy to answer questions at the appropriate time.
Stuart, thank you so much. We have one person on WebEx. Is Bob McCullough from Hazel Health on WebEx still?
I am here. Can you hear me okay?
Bob, you are the prize winner. We can hear you, and you are the last conferee of the day.
Excellent. Welcome. Well, thank you so very much for your patience, Mr. Chairman and committee members. Really do appreciate it, and certainly appreciate hearing all the very passionate individuals that have talked about their mission to be able to serve certainly the residents of Kansas. I think where we're really coming from is we're looking to be able to add to that ecosystem. The committee and the passionate individuals that you just heard from have worked to build an ecosystem to be able to help those individuals. And at Hazel Health, we believe that can be advanced and enhanced by adding telehealth for pre-K through 12 youth. We just believe that there's such a crisis, a mental health crisis that individuals and youth are facing right now. And being able to go into the schools to be able to meet those needs, we feel that we can address some of those issues that you heard from everybody else that's talking about just the crisis that is present. One of the things that is unique about what we are looking to be able to offer is that there is a large philanthropy organization that has come alongside Hazel and has really looked to be able to make this their mission as well, to be able to address some of this youth mental health. And so as part of that ask of $2 million from the committee and from the state, combined with what the philanthropy is looking to be able to offer, we can serve 183,000 of Kansas youth and their families. And so that's what we would be able to look to be able to do. You have some additional information that's in the written testimony, but with that investment, we believe that you will see a significant reduction in depression and anxiety symptoms of youth. You'll see increased attendance, and you'll also see a reduction in disciplinary action. And I thank the committee for your time, and certainly happy to answer any questions.
Okay, Bob, thank you so much for your comfrey testimony today. So I'm going to take a pause this minute, and first off, I'm going to thank everybody who's gutted it out for almost 2 full hours now. Very much appreciate the patience and your willingness to stay within the norm, so to speak. Dayton, thank you for being our timekeeper. But I'm going to pause. Committee, you have a list of 42, I think, conferees. Are there any notes or questions that you would like to ask any of them? Or Representative Reese?
Happy to start us off. My question is for Matt Fletcher.
Matt?
Matt, you said something about the legislature could have language to help slow down the process.
I don't want to. I don't necessarily want to slow down the process. What I want to do is make it better.
Okay.
And I think that that's not going to happen unless you all take some form of action to bring KDADs back to the table in planning their system changes. So that's what we're asking for, is an opportunity to be at the table with KDADs to make their proposals better. We don't want to stop it. We understand the need to respond to the federal government, but these proposals are flawed, and we can make them better.
Okay, thank you.
Okay, committee, other questions? Okay, I'm going to make a general assessment that if you have questions, we have, well, Representative Reese. That's okay. That's what we're here for.
I have another question for Megan. Shreve?
Hi.
You said something in your testimony. It was something that was just mentioned about the 14C transition fund.
Yeah.
Do you have numbers as to who has actually accessed those funds? Because
Right. Yeah. So last year you all put money in the budget for funds to transition, and we hired a consultant. We worked with KDADs, and they have not released their intentions on where the money and when the money will be distributed. So that would be a question for them.
But there are companies that are wanting to access those funds?
Yep.
You know how many?
I think there's about 12 14C certificates left in the state.
Right.
I'm not exactly sure how many plan to access the funds.
Okay. Thank you.
Yeah.
All right, committee, any other? Representative Ballard and then Representative Rivas.
I hesitated because I actually had 6 and I knew that wasn't going to fly. So I'm going to go with Sarah.
Okay.
Sarah, welcome back.
Thank you. Thank you very much. I was very interested in basically a remodeling project.
Correct.
You're talking about. But I'm looking at it in terms of a very small kitchen. Was it 3,200 or 32? I couldn't remember how many meals.
32,000 meals.
30,000. And you serve a 20-county area.
In 2023 and 2024, the residents that came to the shelter, their last known permanent address was from 20 different counties in Kansas. Correct.
And how many helpers might you have to do those meals and to serve those counties?
So one of the duties of some of the residents is to help in the kitchen. We do have a kitchen staff that plans the menus, but it's kind of all hands on deck with staff during mealtime. And we do breakfast, lunch, and dinner for residents and walk-ins.
What would you do if you do not get the funding in order to expand and maybe serve even more people?
Thank you. Right now, I feel that we're putting Band-Aids on a hemorrhaging facility. We keep trying to piece together very small fixes with community foundation grants, asking community agencies, asking churches, and we can't continue doing that. The need is much bigger than a bake sale. I like to say we can't bake sale our way out of this. We need the state to step in and support. We are one of 2 shelters in Western Kansas, and that's Wichita and West. I don't really consider that Western Kansas, but that's Western Kansas when it comes to homeless shelters. Yeah, thank you.
Okay, Representative Rivas.
Thank you, Mr. Chair. I'm not sure who to ask this to, so maybe Matt, but it's regarding conflict of interest. And I know we had an issue this week in the legislature that I got a ton of emails on. The IDD waivers number 2. I got flooded with a lot of stories, a lot of things, but it seems like the IDD proposals with the conflict of interest and with targeted case management are 2 that just bubble up every time. So I guess, what would you recommend, or anybody else that spoke to this could talk?
Sure.
Where do we go? I mean, if we're going to talk to KDAS about this, I want to make sure we understand.
You bet. And that's a great question. So, it's clear from the publishing of the Medicaid settings final rule in 2014 that includes this conflict of interest language in it, that states have been compelled to respond to CMS regarding how they would mitigate conflict of interest within targeted case management systems. Unfortunately, CMS is, they're pretty dead set on seeing a certain approach to that, and that limits in many ways how you would approach mitigating conflict of interest. For example, I would point you to a number of other professions in which conflict of interest is routine and is mitigated in a fairly routine fashion. Anyone who uses a law firm, for example, understands how easily it is for a firm to create a firewall to mitigate any potential conflict of interest. But that's not what CMS is willing to consider here. However, what the state has produced via their vendor, Public Consulting Group, are 2 options which are fairly draconian, even by what is required from CMS. If you look around the country, there are more ways in which states have responded to the federal government than what PCG has put on the table for us to consider here in Kansas. So, for example, in my testimony, I've got a series of things that I pulled from other states that could be considered here in Kansas, and this is not an exhaustive list. There are more. And I think we deserve the opportunity to explore some of these other options, which may, in fact, be a better fit for our state than the 2 that have been proposed to date. So that's a great example of what we're asking for here. We're just asking for an opportunity to come back to the table with more ideas, bring our subject matter experts, the people who do this work, and bring families too, those who will be impacted by their loved ones losing their case managers who they've had relationships with for decades. So if we can do that, I know we can make this better.
Okay. I've got Sarah. You have one more question for Sarah from Representative Reese, and then we have Representative Steens after that.
Thank you, Sarah, for your testimony. I've seen firsthand what happens when law enforcement have people in their sort of custody. They're homeless, and they don't know what to do with them, and I see that they take them down I-70 going west.
You're exactly right.
Yeah. And oftentimes these individuals have a mental illness, a severe mental illness. They lack so many kinds of resources, of course, access to health. I'm assuming they end up in your shelter.
They do, yes. And on the opposite end of the spectrum, if we're no longer able to serve people, all the people that we get will go down 54 in every small town between here, Wichita, Kansas City, to get the resources they need. And then they'll end up in the other shelters, Wichita, Kansas City, Topeka, and those social services systems, which are already inflated, are going to have more need and more people that eventually need to get back to their part of the state they originate from. So, yes, you're correct. They'll end up on 54 or 70.
Thank you.
Thank you. Representative Steens, which conferee?
Yes, thank you, Mr. Chair. I didn't know if our psychiatrist, Matt Byerly, or was it Jessica Provence? Is that how he said her name? Are they still here? Oh, they did. Okay, thank you.
All right. Committee, any other questions? Okay. Seeing none, again, I want to thank everybody who made this as orderly as possible today. Thank you for your patience, your time. I do want to thank Francie for those of you who had to provide information. This is the lady that made it work, along with the revisor's office and research and the IT folks. So it's a big lift putting this together. Committee, thank you so much. A reminder, we are at 1:30 tomorrow. And Francie, it's in this room, not this room at 1:30, not 3:30. So just remember, you got the schedule changed. So you won't be working until 5 o'clock tomorrow night, hopefully. All right, we're adjourned.